Hey there, and welcome to this episode of A Cancer Conversation. Obviously, I am not Chris Curry. He unfortunately is not able to be here today. My name is Lindsey Morris, and I'm the communication specialist with the Georgia Cancer Center. I'm typically the one that's behind the camera, so this is my very first time being host, so please bear with me. Today, I have Dr. Robert Higgins joining us again. If you've been a longtime fan of A Cancer Conversation, he was actually our very first guest for our first filmed podcast, so thank you so much for coming back and joining us again.
You're welcome.
Dr. Higgins is a professor in the Medical College of Georgia, Department of OB and Gynecology. He is also a member of the Gynecological Cancer Care Team at the Georgia Cancer Center. So before we dive into more about gynecological cancer, can you tell us a little bit about yourself and why you decided to take this career path?
Yes, I think since I was in junior high, I wanted to be a physician, though I didn't have any family members who were physicians, and I was fortunate enough to get in medical school after college, and I wanted to be a family doctor. And as I proceeded through medical school, I found a pull to be an OBGYN, so I did a residency in that, and during that residency, I was exposed to older patients who had female cancers and decided that's what I wanted to do, which is called gynecologic oncology. So I did an extra fellowship in that and been doing that my whole career.
And how long have you been here at the Georgia Cancer Center?
I've been here 3 years, but I've been a GYN oncologist since 1989.
Wow, lots of experience. What does it mean for you to work in this field and help these patients?
Well, I think it's a real privilege. I mean, people are coming; they're very vulnerable because they have cancer, and it's a lot of responsibility to try to offer them the best treatments and strive for a cure, of course. And so it's very rewarding when those kind of things happen. Anytime you're an oncologist, though, there are going to be some sad times when things don't turn out the way we want. But I think through the years overall, it's been very rewarding, and the patients are so grateful, and the patients endure a lot when they're getting surgeries and chemotherapy and radiation, and so their bravery and resilience is quite inspiring.
So when we talk about gynecological cancer, what body parts does that entail?
Yeah, so basically we deal with 7 specific cancers. So it's going to be the ovary, the fallopian tube, the uterus, the cervix, the vagina, and the vulva, and then something called trophoblastic disease.
Okay. And today we're going to try to focus more on screening and testing. So what are some of the screening types or tests that patients or just regular women can start getting?
Yeah, I think, the shift has been in all of medicine to try to do more preventive care instead of trying to treat something after it's already occurred. So that's true for cancer and non-cancer. So what we're talking about is applying tests to women or men when they don't have any symptoms and screen to see if they may have a precursor or what we would call a preclinical phase of a cancer that we can intervene and take care of before it turns into cancer. Probably the best one, cancer screening test ever has been the pap smear. And so most women are familiar with that they need to get a pap smear at certain intervals, and if they do that and we catch what we call precancer cells or dysplasia, we can intervene, treat that, and prevent them from developing cancer.
And what age do you think people should start getting screenings done?
Well, it depends on obviously which disease process you're talking about. So for women, the first cancer screening would start at 21 years of age, and that would be a pap smear. And the recommendation currently is for them to get that every 3 years till they're 30 if they're normal. So, and then at 30, they get what they call co-testing with HPV, which is human papillomavirus, which accounts for probably 95% of all cervix cancer. And so you get co-testing at age 30, and you do that every 5 years until you're 65. So that's just an example of one screening test, and the most successful one for women.
Not just screens or tests, are there any other preventative measures that women can take to help against these cancers? Any vaccines or shots or anything?
Well, a couple things. So if we look at cervix cancer, we know there's the HPV vaccine that's been out for about 17 years, I think. And It's recommended that women and boys, girls and boys, get that around age 10, 11, or 12. The idea is to give the vaccine before they become sexually active because it's extremely effective. And as I said before, 95% of all cervix cancer is HPV related. So clearly, if you get that at the proper age, your chances of developing cervix cancer are quite small. When it comes to ovarian cancer, this is our hardest cancer to take care of because usually patients present late with the disease and we don't have a screening test. We do know that oral contraceptive pills, though, decrease a woman's risk of developing ovarian cancer. So that's the one thing I think that women can potentially do if it's appropriate for them to take oral contraceptive pills.
So I know genetics do play a major factor in your increase of cancer risk. Are there any genetic disorders or mutations that people should be aware of that might increase their risk of any type of gynecological cancer?
Yes, this is quite an evolving field, and we're learning things every year about this. But for ovarian cancer, we know there's something called the BRCA gene. That's BRCA-1 or -2. That actually means breast cancer. So that is, if you inherit that gene, you're at high risk for developing breast cancer, but also ovarian cancer. So, for example, the average risk woman in this country, their risk of getting ovarian cancer if they live to 80 is like 1.5%. If they have the BRCA gene, it's 40%. So it's quite strikingly higher. And so for those patients, we recommend they have their ovaries and tubes removed when they finished having children. So that's sort of a prophylactic measure to prevent ovarian cancer.
So if someone has a history of, honestly, at this point, any type of cancer, do you think genetic testing would be a good option just in the preventative field of it?
Well, I don't think we're quite there yet for any cancer. I think for breast cancer, they're going to check women for BRCA. Ovarian cancer, we check people for BRCA. I think probably there's some other cancers I don't take care of that maybe they do some of that, but it's not a universal recommendation that you're going to do genetic testing. You have to know specifically what you're testing for.
Okay. So moving on from the screening and testing, when a patient gets diagnosed, what are the treatment options for them?
So I think we need to break it down because obviously they're different. So uterine cancer, so cancer of the uterus or the womb, that's the most common GYN cancer. And almost always these women are going to have a complete hysterectomy and what we call a surgical staging operation. Many of them surgery will be curative. For some, they will need radiation, and a few will need chemotherapy. So that's just an example. Ovarian cancer, everybody's going to usually have surgery and followed by chemotherapy. It's the rare patient who doesn't need chemotherapy for ovarian cancer. For cervix cancer, it's a little different. So if you catch it early, you usually can do what's called a radical hysterectomy, and hopefully that's curative. If it's more advanced, they almost always get chemoradiation. So those are sort of the three big cancers that we see. So you can see there's definitely some variation.
And what type of cancer in the gynecological area do you see most often, or do you help treat most often?
So if you look at national figures, the most common GYN cancer is going to be uterine cancer. It's estimated about 65,000 women this year will be diagnosed with uterine cancer across the U.S. So, and a lot of that is related to weight. We know that the more you are overweight or that the greater the chance you might develop uterine cancer. So that's another thing that we can all work on probably is trying to keep our weight in a normal range, and that will decrease your risk of uterine cancer. So that by far is the most common one we see. Ovarian cancer is the second most common, and then cervix cancer is third. I will say that it is a little disappointing that cervix cancer is still third because if we could get more people vaccinated, I believe we will continue to see less and less cases of cervix cancer.
When it comes to working with your patients, do you have a specific approach or a philosophy that you like to take with them?
Well, I like to try to emphasize that we are working together. It's not me dictating what should be done. So it sort of should be a collaboration between the physician, and not just the physician, but the staff. I mean, they're interacting with nurses, they're interacting with our PAs or nurse practitioners. So it's really a team effort to work with the patient and her family to offer them what we think is the best treatment. And sometimes they're have had previous experience, so they may be a little hesitant to do certain things, and so we have to try to work them through that. And then if they don't respond like we hope, we have clinical trials here that we can offer patients to enroll in, because this is how we discover new ways of treating things. And sometimes we might offer a clinical trial as what we call frontline or initial therapy, depending on what their disease is.
Are there any clinical trials out there that we need to kind of keep on our radar?
Well, I think any time after you've had primary therapy for a cancer and then it recurs, those that you really want to be looking to see if there are any clinical trials to address your problem. And that's what we have here at the Georgia Cancer Center. We have lots of trials open for women with female cancers. And we're pretty good at getting patients enrolled. And that's usually how we try to manage their disease.
Are there any reoccurring questions that you get from your patients that they ask just all the time?
Well, I think for some there's this sort of guilt, like if they had done something different in their life, they wouldn't have this cancer. For most GYN cancers, that's not the case, but obviously I think everybody's familiar with we don't like people to smoke. We know that increases the risk of many different cancers. For what we take care of, it is associated a little bit with cervix cancer because of the way it interacts with the HPV virus. But for like ovarian cancer, most women have no control, as I like to say, of why they get it. It's nothing they did or didn't do to cause their ovarian cancer. And that's usually mostly the time with uterine cancer, other than the weight issue that we talked about. But for some of the other cancers, yeah, there's, as I say, it's bad luck. And it may be some genetic component we just don't understand yet.
So what are some of the screening tests that women can take?
Yeah, so there's about 4 for cancer screening now. Of course, there are other screening tests for non-cancer things. But for women, pap smears, everybody agrees on that, starting at age 21. And then colorectal cancer, which is extraordinarily common. It's recommended that you get a colonoscopy starting at age 45. And if you're lucky and it's normal, then you get one every 10 years. The other one would be, of course, breast cancer screening. There is a lot of variation in recommendations of when to start mammography or getting a mammogram done. I think the consensus is sort of coming now that you should start at 40, and you should get it every other year till you're at least 75. And the other one that's somewhat new is if you're a smoker and you've smoked at least what's the equivalent of 20 pack years. For example, if you smoke a pack of cigarettes a day and you did that for 20 years, that would be a 20-year pack year history. If you're 50 to 75 and you've done that, they recommend getting a CT scan of the lung, because lung cancer is the most common cancer that men die from, and women too, for that matter. So that's why those are the tests that are available to women for cancer screening.
What are the tests for non-cancer screening, tests that we should be getting anyway just for our health?
Well, I think that's the reason I always ask my patients, do you have a primary care doctor? It's very important that you have a primary care doctor, because they're the ones who should be managing or recommending certain screening tests. So it depends on your age, of course, when you go in and be seen. But for example, at certain ages, you're going to want to have your eyes checked to rule out glaucoma. You want to have your hemoglobin and your blood sugars checked periodically. You want to have your cholesterol and your triglycerides checked for. Those are the kind of things that a family doctor is going to recommend. There's the physical exam that most of the internists recommend that you have. Particularly when you get to a certain age every year. Maybe when you're in your 20s, you don't need it every year. So those are some other screening tests that are out there. even kids when they're born, they get a screening test for something called PKU. So there's lots of different screening tests, but unfortunately we don't have that many screening tests for cancer.
What are some symptoms or signs that women should look out for that might possibly lead to cancer? Something they should speak to their doctor about immediately if it starts happening?
Yeah, I think the couple things. One, if you've quit having periods, we call that menopause, and that's usually around age 50, and you start having vaginal bleeding again, you need to seek care. I mean, that's just not normal, and it needs to be looked into. Now, that doesn't mean you have cancer, but the job of the physician is to make sure you don't have cancer. So that's probably one of the ones that most women know that happens. They need to seek some care. Unfortunately, like for ovarian cancer, there are no specific symptoms. But because a lot of times they'll have abdominal bloating, they get full very quickly when they eat. They feel like they're gaining weight in their abdomen, but they're not really eating that much. But it's not that, or they may have urinary symptoms, like they feel like they have a bladder infection. So unfortunately, that's not something specific I can tell women that like, oh, if you get this, you definitely need to go in. But it's just if you've noticed a change in your body and things over then you need to be checked out.
And for younger women who, aren't in that phase of their life yet, if they begin missing their period consistently, could that be a sign that something might not be right? Not just from stress, but...
So in premenopausal women are still having their periods. If you're having excessive bleeding, meaning that you're bleeding like 10, 20 days out of the month, I mean, those are the kind of things that need to be investigated. Most likely that is a hormonal issue and not a cancer issue, but you still need to have that checked out. If you quit having periods completely, of course, the first thing is make sure you're not pregnant, and then that could be looked into. But again, that usually is not a sign of a cancer. It's usually, again, sort of a hormonal issue.
So is there any messages that you feel like the audience at home you really want to drive home to them?
Well, I think the word cancer is very scary, and the vast majority of people don't get cancer. However, there's about, I looked this figure up today, there's about 60,000 people in Georgia this year will be diagnosed with cancer. We do way better than we did 30 years ago in treating and curing people of cancer, with cancer. So I think the message is it's positive. We're doing much better. We can do better, but we as a society need to do better too when we talk about lifestyle, limiting alcohol, no cigarettes, watching our weight. So there's a lot of positive things and things that, people can take advantage of. I think in our society, though, we have, unfortunately, a group of patients who have trouble to access to care, just physically getting to the doctor's office or having the resources to eat healthy and those things. And that's something that, is an ongoing process in our society.
Well, thank you so much for coming out today and being on this episode of A Cancer Conversation. I really appreciate it.
You're welcome.
For anyone at home, if you have any questions about gynecological cancer or screening or testing, please feel free to email cancer@augusta.edu. We're more than happy to help you out with any of your questions. Thanks so much for listening or watching today. Please make sure that you hit the bell notification or subscribe if you're watching on YouTube, and we'll see you in the next episode.